let's look at traditional prevention and risk factors. We've done this before in the past. It's worth perhaps emphasizing again these simple education, physical exercise, and cognitive exercise prevention approach, because they seem to be working. And I'll give you an update on how certain countries are actually doing randomized studies, non-drugs studies, for prevention of Alzheimer. Now, the genes you're born with, you cannot change them, but I've already said that even if you have this less effective gene, the ApoE4, or even double 4, you can modify that risk over your lifetime if you stay in school longer, if you work in a job requiring a lot of intellectual activity. It's been looked at. Of course, if you're married as a man, and etc. The risk factors for stroke we've talked about. I think the whole room is convinced. Nobody's smoking in this room, right? And we all exercise every day. By the way, what's the minimum exercise to prevent aging? It's half an hour, 3 times a week. It's like getting here and finding you're in the wrong building. I did my 30 minutes today. They're waiting for me. Okay. It's like running between planes in the airport, yeah. So I guess I exercise enough. What is more important is this prevention approach. Physical exercise is really effective at any age. And we're not talking about push-ups, thank God. There's a range of exercise that you can do, and there's a hormone you make in your body when you exercise. It's called BDNF, brain-derived neurotrophic factor. It's easy to measure in the blood. And guess what? It's been shown 2 years ago that the brain gets bigger if you exercise. Not the whole brain, don't dream, but the hippocampus part of it, okay? This was a total surprise. The memory part of the brain gets bigger because of that BDNF, probably. And we're not sure what actually grows in the brain. This is a debate among neurobiologists. What makes your hippocampus bigger? Is it you have more cells, more connections, more glia, supporting cells? We're not sure, actually. But it's not swelling. It's really bigger, nice looking on the scan. Okay. Education, again, as a population, we did well compared to rural China and India, where in these countries, if you want to prevent dementia, you should keep people in school longer and feed them well in school, etc. Well, I hope we're beyond that now. But we still we have to make sure boys stay in school longer, eh? Do you have a lot of dropouts here with boys? We do in Quebec, yes. So, grade 7 has been sort of the epidemiologic cutoff. If you make it above grade 7, there is like a difference of 5 years. So 2 identical twins, one is a dropout, grade 4, you went to work for McDonald's, and the other one is grade 10 or more. What's the difference in age of onset between the 2 of them for dementia? Difference is 5 years. And will they die at the same time? Yes. The highly educated one will catch up with the low educated one. Sorry, guys. So you stretch your brain reserve longer if you have a higher education. It's called the brain reserve concept. If you're bilingual, is your brain bigger? Absolutely. This was very distressing for people in Toronto. Especially Mayor Ford, he's still not recovered. Yeah. Now, if you combine education and physical activity and cognitive activity of some sort, this has been tried in some studies in Finland, Sweden, and France. It's called different names like FINGER and MAPT, M-A-P-T. And people who are 70 and over, frail, elderly, not demented, will have the results next year. But it's expected, yes, there will be an improvement of their cognition, however you measure it. It will be interesting to see the brain changes. We already know from work done in Montreal that if you train people with MCI, with a coach twice a week, memory training twice a week for a month, first of all, their memory is better for a year. And if you look at their scan with MRI before and after, they're different. Not that your brain is bigger, don't exaggerate. But the way you use your brain, the functional MRI is changed. So instead of using like 5 different parts of your brain to learn the stupid list of words, after training you need only 2. Okay, so yeah, you go back to normal. So there is a rationale for using cognitive training. And hopefully by next year we'll have some of these programs online. The European programs that will be completed next year, we want them online, and also the Montreal program, which will be matched with the Seattle program for executive ability, merged together. As soon as we prove it's actually good compared to people on the waiting list, This should be made available to everyone, and I think every doctor should take those courses so they'll remember to be on time. You hinted that we're always late. Not all of us. Okay, something also that's coming online, it will be an app. For those of you who have an iPad or iPhone, it's going to be something called Dementia Risk Score. It's kind of a common sense thing that you can do on your own. So this is based on study done in Finland 25 years ago. They asked a bunch of people in their 50s, please answer these questions. How old are you now? What's your formal education? How much sex you have? No, it's gender, okay? Blood pressure, BMI, cholesterol levels, if they know, and physical activity. And you see the numbers, it's bad to have high numbers, right? So if you're older at the time they start the survey, if you have low schooling, if you're a man, the Y chromosome, weak people, yeah. And then if you have hypertension, if you're overweight, if you have high cholesterol, if you have physical inactivity, 20 years later, who's got dementia? So some of them. And those who had the higher score, 10 and above, it's 7 times risk compared to people with a low score. And then if you have 12 and above, it's 16 times. So this dementia risk score can be done soon by anybody online. And it's very visual. So you say, you enter these numbers, and then your risk score is like 12, and oh my God, I got 20 years now to fix this. That's very motivating to quit smoking, to get a woman, to whatever. Yeah. Yeah. Now, this is a requirement to enter some of the prevention studies. So in the finger study in Finland now, you have to have a dementia risk score of 8 or more to be enrolled in the study. And then they get physical exercise with a lot of supervision and cognitive training with supervision and some kind of diet. But they have fish already 3 times a day, so that's not really a big change. But they would be for us. And then you need 5 to 7 years if you really want to follow people until dementia. So that's kind of too long, eh? You could have shorter studies if you maybe just look for memory decline, not wait for dementia. So there are different ways you can do that. But it's been tried with ginkgo. So ginkgo was done in France, 7 years. No difference after 7 years. Sorry. And in the States, it was done also. It was a bit of a shorter study because they chose people who were a little forgetful, but no impairment. So pre-MCI, it's a new term. Subjective cognitive impaired, new term. It's like us on Fridays, right? At the end of the day. Okay, how about people with MCI? If you want to follow them until dementia, the study could be as short as 3 years. Now, to get into those studies now, you have to be more than forgetful. You need to have a PET scan that shows amyloid or spinal tap that shows you have low levels of the protein. It's more complicated than it used to be. Also, if you have ApoE4 to start with, what is your risk of getting Alzheimer in 3 years higher or lower? Much higher. Yeah, there's a big difference in prediction of progression from MCI to dementia if you're ApoE4 positive. That's known now. So you have to stratify, you have to divide up the people equally between those who have the, let's say, less efficient gene and those who don't. And this is an example of a study that was done with such people. This is 3 years of treatment with donepezil, vitamin E, and placebo. This is vitamin E high dose, 2,000 units a day, which is still considered as potentially toxic. No difference at 3 years. And every drug that's been tried, whether it's Zocor for cholesterol in these kind of patients, anti-inflammatory drugs, COX-2 selective, I think natural, whatever. I know you like herbs here, is it true? Half of Vancouver is you buy herbs, you smoke some of them, and you make tea with some of them. And with the other doctors were telling me about this yesterday, they don't have a clue about half of what the people actually take, especially near White Rock. You know this place? There's greenhouses all the way, and is this something called BC Gold? Really? Okay, anyway, I'll find out what that is. Okay, the high-risk population. So I'm back to my young people who are 30 or 40. In BC, there are some families. They're scattered. No, I guess it's north-south here. These are isolated families where if the mother or father had Alzheimer at 40 or 50, what's the risk for the children? 1 in 10, 1 in 2? 1 in 2. It's a dominant gene. Same age as the parents, full penetrance. And these are rare. And it's a big weight to carry all your life. So you're 20-year-old, you know your mother had Alzheimer at 40, she's still alive, maybe. Are you going to get married or not? Yeah, but are you going to have children or not? So sometimes you get genetic counseling. You have resources in Vancouver to do that. They had no studies for them because they were younger than 55. The old rule about clinical trials for Alzheimer is 55 to 90. Why? Who knows? They figured, I guess, over 90 you're going to die of something else before you finish the study. Okay. And before 55, maybe they're so unusual and rare we don't want them because it was thought that if your Alzheimer's starts very young, you'll decline faster. It's not true, actually. It's not really true. It's just you have less comorbidity. Bottom line is, this data, which was presented at the Vancouver Congress here in 2012, is based on, again, spinal fluid exam and scans in people who are at different ages from these families. And the time zero, the vertical bar, is the age of onset of dementia in the mother, father, or older brother and sister. And you see that minus 10 years, there's already a lot of changes in the brain, and even minus 20 years. So now we're looking for these people across BC, the Greater Toronto region, and the Montreal Greater region. They will be offered to have a treatment that will prevent the amyloid buildup in their brain over 2 years. It's too short to prevent dementia, we know that, but it may be long enough to show a change in these curves. And as soon as we have a signal, one of the drugs is actually making a difference, they can continue on the treatment longer until we can show there is a delay of progression towards dementia. It's the first time they get access to modern Alzheimer treatments. So if you know families like that, send them to Dean Foti, Howard Feldman, Seong, the team at the UBC, and they will be seen very quickly. This is an example of a PET scan in such young people. The one in the right is time zero, so he's expected to have symptoms very soon if he doesn't have any. But you see, the red is the amyloid buildup in his or her brain. Minus 10 is another person, maybe from that family or some other family, with the same mutation. You see, the yellow is already amyloid buildup, minus 10. So these are the people we're looking for, minus 10 to plus 5 relative to age of onset, and they will be given at random the 2 of the anti-amyloid drugs or a placebo. And to make it easier for them, there will be also some people who don't have the mutation from those families who will be randomized in the study. They will all get placebo, obviously. If they have no mutation, there's no amyloid buildup. We should not give them a drug for amyloid, but they're in the study. So that dilutes a bit the impact that if you sign up for such a study, automatically the employers and everybody knows you're a mutation carrier? No, because there are some in there who are not mutation carriers. It's a way to soften the blow from employment perspective. I'm going to come back to that issue in a minute. This is a 63-year-old man in Montreal with no symptom. So the yellow here is the amyloid buildup. And what do you tell someone like that? It could be someone who went to Seattle with $5,000, I want the scan, and he comes back with this picture, or the report positive. We're not sure what that means. But now it's a research test. There's 3 different ligands in the States. In Canada, we're testing another ligand that will be even, that we think, better, coming from Sweden. And eventually there'll be one ligand approved in Canada for use clinically. Just to let you know that doctors in Canada interested in dementia, we're proactive. We prepare guidelines for use for the technology that will correspond to the need of the people. It's not like driven by industry or governments, so it's from the bottom up. And we get also persons who are at risk to be involved with these discussions. So the last round of guidelines we published a year ago, we had a person with mild cognitive impairment to help us think through. And that's a trend we're going to see now in many ethics committees, planning committees for these prevention studies. We will have people who are involved because they consider themselves at risk, sort of users, involved with the planning and the implementation. So to finish, this is in tab 11. It's a remarkable article written by Dr. Illis. It's part of a supplement in Neurobiology of Aging It's not the kind of journal where you expect ethics papers, but they did something unusual. They gave us a year to write a position paper on ethics in ALS, in Huntington, in Alzheimer research, and you have the good fortune to have an illegal copy of the article by Dr. Illis, and Peters is the lead author on that one, but he worked with 3 people from Vancouver to have this paper, and this is an illustration from the article that makes the point. At the bottom is a risk of treatment from low to high, and above that is risk of getting dementia from low to high, and they break the boxes into no genetic risk to some genetic risk because of your family history, with or without blood tests showing ApoE4, and then on the right, the high risk, your mutation carrier, the young people I told you about. The message is there has to be some balance between risk of treatment and risk of getting dementia later in life. And the ethics committees are very sensitive to that. We'll see if decision makers in governments also will be sensitive to that. The debates we've experienced here in this province and elsewhere in Canada about paying for drugs for dementia, this is trivial issues compared to the infusion of drugs every month for 2 years minimum. People, this is going to be real serious debates here. Do you give infusions to people who are 90? It's going to be a bit like your dialysis discussion. So, bioethics, yes, they're here to stay. You've chosen a good business to be in. And some considerations for you to think about. Remember that if you say to someone who has mild cognitive impairment is fully aware of what's happening, full insight, careful what you say, eh? Catastrophic reactions are possible. The guidelines for who needs these tests, they're not done yet because we don't have the data to predict. If you have a positive scan, what does it mean? Access to high-tech markers. You're lucky in BC, you have Vancouver, you have all the machines, the doctors, but if you live in the Philippines and Hong Kong and the third world countries are really worried that this technology, we're going to create 2 kinds of neurologic medicine, and we reassure them by saying, honestly, if you do a good memory test, it's probably as good as all the biomarkers we have right now. Another consideration is probably a spinal tap will give you as much information or more than 3 scans. So I know nobody in Vancouver likes a lumbar puncture, but if it's done by a doctor who's really good at it, you may want to reconsider. Because from a cost effectiveness point of view, you get a lot more data from 1 lumbar puncture than 5 scans or 4 scans. Okay. Examples now to just nail this carefully. So ApoE4 study, it's a study where they're looking for people who are double 4, no symptoms. That's 3% of people in this room, 3% of the population. If you have a double 4 in your medical file, is that good for you when you look for a job? Or probably not. And your kids don't want to know, eh? Right, because if you got 2-4, all your legal children have 1 copy, right? Okay. So if you read the consent form, the first page, the heading, study for people who are double 4. You sign, and then they tell you, oh, you're so lucky you're in the study. What does that mean? Yeah, okay, you're double 4. If you're in the study, the heading is study for people who are amyloid positive. You get the scan, oh, you're so lucky, you're in. Okay, so there has to be a way to soften the blow, to explain before you even sign up. What does it mean? It's just a risk factor. It can be compensated in different ways. If you're interested, we can be more aggressive, and the risk of treatment is this and that. If you are a carrier of a mutation, then you get this complicated protocol over 2 years, but we soften the blow by diluting the information with mutation non-carriers who also get into the treatment. And nobody's being told if they're mutation carriers or not. If they want to know for other reasons, like planning for children, etc., this is done separately by a clinical genetic program. Another thing we do is we have people who are participants joining the programs, as I said. We have data safety monitoring committees. So these are people who are independent of the programs. They look at the data as they come. We have rules about stopping the study if it's futile. Remember that word, futile? So if you have a 7-year study, you're comparing 2 groups, and at 4 years, there's no difference. There's no way there'll be a difference at 7 years that will be meaningful. We can stop now. The opposite, we all dream of that. After 3 years out of 4 or 5, there's already such a big difference. you cannot continue ethically because you're depriving people of the effective treatment. We haven't seen that very often. So there are ways to modify the study based on what's happening. And now the LC committee. So this is something where Judy Ellis, which you'll meet later this afternoon, has a lot of experience with. It's committees that are ethical, legal, social impact. It's structured of mostly ethicists, but also lay people and people with knowledge about the social impact of what you're doing. So think about it. Let's say the infusion of drugs over 2 years is delaying progression. Are you going to do that with everyone who's over 65? Really? It's not doable. We can't do it. So that has to be thought through ahead of time. Are you going to do a PET scan on everyone or lumbar puncture on everyone over age 65? Of course not. Not doable. Maybe we should do an MMSE or MOCA. Maybe people with no symptoms, right? No. How about just asking a question when you have your annual physical? Have you had any memory change in the past year? Which is the current guideline. Just ask a question. But if you say yes, or the person with you says, yes, there's been a change, the doctor has no time to do further workup. Should you bring them back for a second visit? Yes. That's the proposal made by Dr. Rockwood in that house. So we can still improve the way we deal with memory complaints. There's a difference between what you call screening in people who have no symptom and asking just appropriate question. If it's a yes, then you can probe deeper. I just want to reassure people in the room, we're not trying to medicalize aging. We just want to help people who have memory complaints, and we can help them to go as far as they want in the workup and the treatment. So personalized medicine is very much, I think, the reality of what we're doing now in Canada for diagnosis and early treatment, timely treatment. Timely diagnosis and timely treatment, maybe this is the word to remember from today. So to conclude, exciting times. We have the resources in Canada to do essentially all these studies. We just have to decide together, do we really want to do all these aggressive treatments in people with no symptom? Or should we focus on the high-risk group? I favor the later. Can we have in place these LC committees for all the big programs to make sure that what we do is socially meaningful and useful? So that's it. Thank you very much. Merci.